Welcome back to our new video on ST-Elevation Myocardial Infarction. Let's begin with the simple understanding. ST-Elevation Myocardial Infarction is a severe manifestation of coronary artery disease, characterized by the sudden occlusion of a coronary artery, leading to myocardial ischemia and subsequent necrosis. It represents a medical emergency requiring prompt recognition and intervention to prevent significant morbidity and mortality. Clinical features include chest pain. The hallmark symptom of STEMI is severe, crushing chest pain that may radiate to the neck, jaw, shoulders, or arms. It is often described as pressure or tightness. Shortness of breath. Patients may experience dyspnea due to decreased cardiac output and pulmonary congestion. Diaphoresis. Profuse sweating is common and may accompany chest pain, nausea, and vomiting. Some patients may experience gastrointestinal symptoms. Anxiety. Feelings of impending doom or anxiety are frequent. Syncope. In severe cases, patients may experience syncope or loss of consciousness due to decreased cardiac output. Diagnosing ST-Elevation Myocardial Infarction involves a combination of clinical assessment, electrocardiogram findings, and biochemical markers. Here's a step-by-step guide to diagnosing STEMI. Clinical assessment. Evaluate the patient's history, focusing on chest pain characteristics, associated symptoms such as shortness of breath, nausea, sweating, risk factors for coronary artery disease, such as smoking, hypertension, diabetes, and any previous cardiac history. Perform a thorough physical examination, including vital signs, heart and lung auscultation, assessment of peripheral pulses, and signs of heart failure or shock. Electrocardiogram. Obtain a 12-lead ECG as soon as possible, preferably within 10 minutes of patient arrival. Look for characteristic ECG changes consistent with STEMI. ST segment elevation of at least 1 mm, which is equivalent to 0.1 millivolts in 2 contiguous leads in men younger than 40 years, or at least 2 mm in men 40 years and older, or at least 1.5 mm in women in leads V2 to V3, and or at least 1 mm in other contiguous leads. New or presumably new left bundle branch block may also indicate STEMI equivalent. In addition to initial ECG, serial ECGs may be necessary to detect dynamic changes over time, especially if the initial ECG is non-diagnostic, but clinical suspicion remains high. Biochemical markers. Cardiac biomarkers, particularly troponin, are essential for confirming myocardial injury. Troponin levels typically rise within 3 to 4 hours of symptom onset, peaking at 12 to 24 hours, and remain elevated for several days. High-sensitivity troponin assays allow for the detection of even small elevations, aiding in early diagnosis. Elevated troponin levels in the appropriate clinical context support the diagnosis of myocardial infarction, but they are not specific to STEMI. Imaging studies. Additional imaging studies such as echocardiography or cardiac MRI may be performed to assess left ventricular function, detect wall motion abnormalities, evaluate for complications such as ventricular septal rupture or papillary muscle dysfunction, and guide management. Risk stratification. Once STEMI is diagnosed, risk stratification is crucial to guide management decisions, including the need for urgent reperfusion therapy, like primary percutaneous coronary intervention versus fibrinolytic therapy, and intensive monitoring in higher-risk patients. Differential diagnosis. Consider other conditions that can mimic STEMI, such as pericarditis, aortic dissection, pulmonary embolism, or other causes of acute coronary syndrome, such as unstable angina or non-ST-elevation myocardial infarction, especially in patients with atypical presentations or non-diagnostic ECG findings. In summary, diagnosing STEMI involves integrating clinical assessment, ECG findings, and biochemical markers to promptly identify and initiate appropriate management. thereby reducing myocardial damage and improving patient outcomes. Early recognition and treatment are essential in optimizing patient survival and minimizing complications associated with acute myocardial infarction. Complications: arrhythmias. Ventricular arrhythmias such as ventricular fibrillation or ventricular tachycardia can occur, leading to sudden cardiac death. Heart failure. Due to significant myocardial damage, heart failure may develop, leading to pulmonary edema and systemic congestion. Cardiogenic shock. Severe myocardial infarction can lead to cardiogenic shock, characterized by profound hypotension and end-organ hypoperfusion. Left ventricular aneurysm. In some cases, myocardial infarction can result in the formation of a left ventricular aneurysm, predisposing to thrombus formation and embolic events. Pericarditis. Inflammatory response to myocardial infarction can lead to pericarditis, characterized by chest pain that worsens with inspiration. Ventricular septal rupture. Rarely, the infarcted myocardium may rupture, leading to a ventricular septal defect and hemodynamic instability. Management. Immediate reperfusion. The primary goal in managing STEMI is to restore blood flow to the occluded coronary artery promptly. This can be achieved through either primary percutaneous coronary intervention or fibrinolytic therapy. Aspirin. Administer chewable aspirin 160 to 325 milligrams as soon as possible to inhibit platelet aggregation. Oxygen therapy. Administer supplemental oxygen to maintain oxygen saturation above 90%. Nitroglycerin. Sublingual nitroglycerin can be given to relieve chest pain and reduce preload. Pain management. Analgesia with opioids like morphine can alleviate pain and reduce sympathetic stimulation. Antiplatelet therapy. Besides aspirin, P2Y12 inhibitors like clopidogrel, ticagrelor, prasugrel are administered to inhibit platelet aggregation. Anticoagulation. Heparin or low molecular weight heparin is used to prevent thrombus formation. Beta blockers. Beta blockers reduce myocardial oxygen demand and prevent arrhythmias. ACE inhibitor angiotensin receptor blockers. These drugs improve outcomes post-myocardial infarction by reducing ventricular remodeling and preventing heart failure. Statins. Statins are prescribed early to reduce cholesterol levels and stabilize plaques. Finally, STEMI is a critical condition associated with high morbidity and mortality. Prompt recognition, early reperfusion therapy, and comprehensive management are crucial in improving outcomes and reducing complications. Timely intervention can significantly mitigate myocardial damage and improve patient prognosis. Therefore, healthcare providers must remain vigilant for signs and symptoms suggestive of STEMI and initiate appropriate management without delay.